Hi everyone, welcome. I'm Susan Birch and welcome to another Health Detective Q&A. And tonight we've got Dr Estrelita van Rensburg with us, talking to us about hormones and answering all our questions. So thanks so much for coming, Estrelita.
Absolutely delighted to be here with you, Sue, and everybody that's listening to us today.
Yeah, it's such an important topic, and I know that you run a special program for women around hormone recovery and menopause. So I thought you're going to be the perfect person for everyone to have a chat to and hear what you've got to say. So we'll get into the questions. So we have quite a few questions that have come in. So the first question really is, what is menopause? What are the symptoms?
Well, I think it's a great place for us to start, and it's very important, and I think it depends on who we ask, what they will say, what menopause is. But let me start with a traditional Western view of menopause and what Western women typically experience. This is a time period where most people or most women is dreading menopause because they know that that's the time when we experience hot flushes, mood disturbances, anxiety, insomnia, as well as an increase in weight. So it's a time where women really feel uncomfortable, but it's actually more than that. I think it's not just the symptoms that women in the West experience typically, and I'll come back why I emphasize the West, but it's also their loss in status, because in the West, it's perceived that women going through their menopause, they're getting older, they're getting more unattractive. And it's almost as if there's this mindset that women become useless as they're getting older. So it's a loss of status and all of that going with that. So it's really a difficult time. But if we look a little bit wider, so it's not just, I would say, a medical condition. I think there are other factors as well. There are cultural, social, historic, geographic, and lifestyle issues that we need to consider when we talk about menopause. Why do I mention geography and history and things like that? Because it's not the same. Menopause is not the same, hasn't got the same connotation in traditional societies compared to what we in the West experience. And what do I mean by that? Well, there's a lot of research being done on that. And we know if we look globally at traditional societies, and I'll mention a few, of course, these populations are dwindling. But let's start in the West with the traditional Mayan people of Guatemala, Mexico. We can go north to the American Indians, specifically the Cree population of Canada. We can come over to Africa, many traditional societies there, and then New Zealand. The Maori population. And what is different about the women in these traditional societies is that they don't experience menopause in the same way that we in the West experience it. They don't complain about hot flushes. They don't see the insomnia. They don't see the anxiety. And they actually have a very different view about menopause. They actually see it it's a normal physiological process, as we know. All women go through it. It's the change from the reproductive phase to being non-reproductive. But in these societies, it's actually a very important phase of regeneration for women. So they feel very positive about it. their role in society actually becomes more important and not less important. They are actually being revered in their societies. They're being seen as the wise women that's got a mentoring role for younger people and children. So it's an amplification of status. Now, can we actually, all the symptoms that Western women typically experience, just put that down to these cultural and social factors? Of course not. There must be something else, because the symptoms that we typically experience are very real, and we know that. So what else is going on here? And very interestingly, they've actually done studies to look at a comparison between women in a, say, traditional society and a Western society, looked at people that, experience hot flushes, and then look at hormonal levels. And there wasn't really a difference in their female sex hormone levels between traditional women and Western women, that they're so different experiences. Sorry. So what is the issue? There must be something else. And what I'm coming to is they've also seen that women with hot flushes, there's a significant association with insulin resistance. And I think this is the topic that we need to bring into this discussion, because it's not recognized, and it's not recognized really by most of the medical community, and certainly not the patients that they're treating, because everybody thinks it's the female sex hormones that's driving this. I beg to differ. I don't think so. I think that what we're looking at here is that there's another condition, a very real condition of insulin resistance that's underlying these symptoms that women experience, especially in the West. And I mean, we can go on to the next question, which probably is, so why do we see insulin resistance more in the Western societies and not in the traditional societies? And of course, there are very good reasons for that. But I'll take a pause just there for a moment.
All right. Well, the next question that came in was really another version of what you've just been talking about. So I'll share it with you. It says, is there a relationship between hormones, sleep, and weight control? And so I'm pretty sure you're going to come back to insulin resistance again in your answer there. Yeah.
I mean, hormones are very important because it regulates everything that happens in our bodies. So the hormones is like the conductor of the orchestra. It's very complex. And when we start to improve certain levels of hormones through medication and therapy and so on, I think it's quite a dangerous route that we go on, because it's so complex. And I don't think from a medical perspective, we really understand all the subtleties of these hormone interactions. But what we do know is that some hormones are more dominant than others. And the one hormone that's very dominant is insulin. Now, just to remind listeners, what is the function of insulin? Insulin actually is the hormone that lowers blood glucose. So when we eat, and especially if we eat a high carbohydrate diet, there's a lot of glucose in our bloodstream, and insulin takes the glucose from the blood into our cells and into our tissues, because glucose is used for energy, which is what we need to live and all the metabolic processes. But if the insulin is high, there's a second function which most people don't know about, and that is the fat storage function of insulin. Insulin actually builds fat. So if we have high carbohydrates and glucose, over time, we're going to store fat, especially in our abdominal area. in and around our organs. Now, this is one of the very, very common symptoms that women experience during menopause, but it's not your female sex hormones that's responsible for that. That is because of insulin. And if you think, and I mean, I thought the same actually when I went through my menopause, is I just need to boost my female sex hormones a little bit and I will feel much better. Well, funnily enough, I didn't. Because I didn't target the right issue, which was what I eat, and I didn't target my insulin response, because insulin is going to dominate everything else that's going in your body. And if you think that by taking HRT, you're going to actually alleviate these symptoms, I think, you know, you're going to be in for a surprise, because it's not the right thing that's being targeted.
That's interesting. And I also think when you look at stress, so, you know, going back to your first point earlier, and as we're getting older and we feel less valued, and sometimes stress can increase, and then that increases blood sugar as well, and that has that dramatic effect on insulin as well, and so and also on fat storage.
Oh, absolutely, Sue. I mean, with stress, the hormone there is cortisol, as we know. It increases cortisol. And very interesting, cortisol and insulin has got actually not the same function, because cortisol wants to increase glucose. Why? Because it's a very, you know, a response in our body to try to have energy available when we stress, so that we can get our muscles moving and, you know, the fight and flight kind of thing. So cortisol wants to increase glucose, where insulin wants to decrease it. So if we stress all the time, that's going to increase glucose in our bloodstream. The result of that will be obviously that our insulin levels are going to increase as well. And over time, stress can significantly boost the insulin resistance that will develop over time. And because of that, there's going to be more fat storage as well. So stress is another important factor that will amplify any insulin resistance that there is. And we need to know that, and we need to think about what the stressors in our life is, so that we can deal with that, because it will impact how our body responds and the hormonal levels.
And then I think that our sex hormones, once we reach menopause, are also, you know, majority of them are made in the adrenal glands with the cortisol. And so if we're under chronically high stress, we may not have enough of the kind of building blocks that we need to be able to pump out adequate levels of all these different hormones.
Yeah, and I think, you know, we also need to understand that, you know, as we get older and older, you know, of course, there are going to be changes in our hormone levels. It's a natural process. It's something I think that we also need to accept. But that is not supposed to make us sick and give us a lot of symptoms. That's not how humans are traditionally designed. We should go through the changes, the life changes, the hormonal changes, without experiencing a lot of severe symptoms and disease. But that brings us back to our lifestyle and fundamentally what we eat. So, I mean, for us in the West, we know that over the last half a century, really, we've seen so many more diseases, chronic diseases. We've seen so menopausal symptoms and so on, I think is just so much more prominent as well. And all these things tie together back to the lifestyle and the changes that were introduced basically after the Second World War, around about the 1980s, when governments started to tell their populations what they should eat. And this was all backed by the food industry, which greatly benefits from the dietary guidelines that we have. And it's almost global at the moment, because of the explosion of processed food availability. And it's not just food, it's drinks as well in our supermarkets. We're being brainwashed that, it's not cool any longer to cook in a traditional way, to eat traditional food. This is a fast food outlet. It's the modern lifestyle. Unfortunately, all of that is part that is really making society sicker and sicker from a metabolic perspective.
All right, I have a few other questions here, so I might try and group them together a little bit. So there's a question about, is HRT safe and do I need medication? So you have been sort of talking about that, but I think the safety of HRT is probably something worth touching on. But I will just say that you can't give any individual medical advice here. So this is just general concepts.
Yeah. I think HRT, whether you want to use it or not, is really a discussion between yourself and your healthcare provider, your GP, who will be able to, or should be able to, give you a lot of information about the safety, possible side effects and so on of using HRT. Personally, as I mentioned earlier, I have used HRT myself in the past, but if I would go through that menopausal phase again today, I will approach it very differently. And I think that is what I would like to impart today in this discussion is, when you suffer from any of these so-called menopausal symptoms, just take a pause, and you may want to frame it a little bit differently and say, this is something metabolically that's probably going on in my body. And before I embark on hormonal therapy or anything else, just check if you are not insulin resistant first, because you're going to have a much greater success rate in dealing with your symptoms. And we're talking about physical and mental symptoms by actually dealing with insulin resistance. You may have high insulin levels. That's normally not checked by our GPs. It's not a test that is requested traditionally. It can be quite an expensive test, and GPs are really not trained in how to evaluate and even request insulin. So it's probably not something that for most people is going to be easy to obtain. So what do they need to do then? If you can't have an insulin test that's readily available, what can you check for? Well, there are a couple of other markers that I would advise people to check first. The first one is your hemoglobin A1C. Now, hemoglobin A1C is really the level of our glucose for the last 3 months. And that's a very good indication related to what we eat in our diet. The second thing that I would really think people should look at is their triglyceride level. So this is typically part of the lipid profile that's available, and it's tested constantly. But I would not be so concerned about the cholesterol values, which is the traditional values that doctors are concerned about, but look at your triglyceride levels. That's the blood fat level. And if that's high, it tells you that you're eating too much carbohydrates. So both of those, hemoglobin A1C and serum triglyceride levels, I would say are very, very important. There are others as well that we can talk about, but this will be my starting point, and I will not run to get some HRT before I haven't made sure that I don't have an impact in my glucose insulin metabolism.
I do wonder though about HbA1c on an individual basis, because if someone has an early stage of insulin resistance, the whole point of the insulin is it keeps that glucose down. So sometimes that can be a little bit misleading. People are told it's you're great, you're great, you're great, until suddenly you're not. So I think that can be one issue there. And the other thing is, you know, they always keep telling us that insulin is really expensive. Well, it costs $45 in New Zealand. And, you know, I don't know what other people think, but I don't think that's a particularly expensive test to run or to go and pay for yourself if your GP won't allow you to have it funded. And I think given the cost of things like medication and HRT and doctor's visits and all the other things that go on, I think it's probably quite a cheap test, really.
It's a very good point, Sue, and I say it's expensive because here in the UK, I had the test done privately and it was £150 to have it done privately. So that's quite expensive. But I completely agree with you. There's no reason why it should be expensive at all. And in New Zealand, that's good news. If people can get it for that price, they should go for it. But the point that you make is we cannot just, I mentioned 2 markers, but there's much more to look at. Before you even go to the lab test, the first thing that you need to do is take some measurements. Take your height measurement and take your waist measurement. And your waist measurement should not be more than 50%, half of your height measurement. So the relationship should be 0.5. If it's 0.5 or less, then you're probably okay with regard to fat storage. Anybody can do that. You don't have to spend a penny to take the measurements. You can do it yourself. If it's more than 0.5, you've got too much abdominal fat. And that already gives you an indication. So the going to the laboratory test is additional. I mean, we work a lot with laboratory tests and monitoring people for their metabolic status, and it's probably because I'm very interested in that. My background is laboratory medicine. That was what I spent most of my professional life in. The unfortunate thing about the lab testing is that the normal reference ranges that are actually quoted when you go to the lab and they send you your results are not really in the healthy metabolic range. And what do I mean by that? What I mean by that is over the last decades, as the general population is getting more and more metabolically unhealthy, these ranges or normal values as we see it as increased. So normally a laboratory trying to say what is the normal range for any marker, and I'm taking typically something like our liver enzymes, and they take 100 people, test them, and then they take an average, and that's what they say, so-called healthy people, that is what is normal. But we know with the condition of insulin resistance that it's like an iceberg. Most of insulin resistance in the beginning is subclinical. People are not aware that they're insulin resistant. So I mean, it's estimated in the US now that 88% of the adult population is already insulin resistant. Mm. So when the laboratories start to establish their normal ranges, that includes a high percentage of people that's insulin resistant. So these ranges have moved upwards and upwards when it actually people are already insulin resistant at lower values. So that's what we try to take into consideration, because one of the organs affected by this is our livers. And so fatty infiltration in the liver, when I was a medical student, that was very typical of people with alcoholics, with high alcohol use. But we know now that a high carbohydrate level, fructose and glucose and so on, do exactly the same changes in the liver as alcohol. And it's very common. And you can see that in the liver enzymes, which is a very cheap test to do, but it's possibly not going to be diagnosed early enough if you look at traditional reference ranges. So I think, so just to go back, do your body measurements. That's the first place. If you suffer from any of these symptoms, whether it's hot flushes, whether it's weight gain, whether it's anxiety, mood disturbances, all of these things, first think about insulin resistance and don't label it as menopause until you've got somebody that actually practices in metabolic health and can evaluate that for you. And if you've cleared of being insulin resistant, then think about maybe other hormonal effects and so on. I would think that most people, there will be very few that can't be helped in this way.
Great advice. I have another question. Why do women often develop heart disease after menopause?
Yeah, excellent. Very good example. Let's see what diseases follow on insulin resistance, because there is a progression. As I say, this is the metabolic abnormality. And as insulin resistance is present, over time, different diseases manifest because of that. Heart disease is one of the diseases that follows high blood pressure, stroke, heart attack. Those are all related, but the precursor is insulin resistance. In some people, it can be diabetes, the development of type 2 diabetes. In some people, over time, it can be the development of dementia. It's just different organs in our body that become resistant to insulin. So it can affect the heart, it can affect the brain, as I just mentioned, because if our brains become resistant to insulin, it's called type 3 diabetes or dementia.
And what about breast cancer? Can I throw breast cancer in there? Do you have it?
Yes, absolutely.
Connection with breast cancer.
Yes, I mean, once again, the traditional view of cancer is that it's a genetic disease, or it's got a very strong genetic underlying component. And yes, there are cancers that have very specific genetic mutations, but those are in the minority. Most of the cancers that we see today, so it's the prostate, esophageal, breast cancer, colon cancer, and so on, there's definitely a metabolic component behind the development of these cancers. And a couple of interesting points with regard to that is that in breast cancer, to take your example, that it's been shown that the breast cancer cells have many more insulin receptors than normal breast tissue. So it's already very primed and sensitive to insulin. So if you have a high insulin level, I think you're in trouble if you have breast cancer, because what does it do? We also know that cancer cells are very dependent to get their energy from glucose. They are extremely dependent on that. That's research that's already been done 100 years ago. It's been known to us. And even if you go for a scan, if you have cancer and they want to detect where the cancer is, where's the primary, if you have metastases and so on in your body, they do a PET scan. Now, a PET scan is basically they label glucose, make it radioactive. And the interesting thing is that radioactive glucose go and lodge in, it tells you where the cancer cells are in the body. So there's a very strong relationship between diet, high glucose, high insulin as an underlying metabolic mechanism for the development of these cancers. And just a last point that I want to make on this topic is we've seen a dramatic increase in all of these cancers, you know, breast cancer in women, colon cancer. It is so common these days, prostate cancer and so on. Once again, these diseases that become more and more and more common in our modern society can all be linked back to an underlying metabolic mechanism.
And just one other thing about insulin is that it's an anabolic hormone, so it makes things grow. So, you know, it helps make our muscles grow, but it makes our fat cells grow and it makes the cancer cells grow as well.
Absolutely. And I think this is really the key message, maybe not the message that many people want to know, but the key message of today is really that these chronic diseases, whether it's cancer, heart disease, diabetes, and I will actually put obesity as part of that. These are not normal for us as humans. It shouldn't be there. It's never been there in traditional societies. I mean, what is left of them, and previously there's been a lot of work done because scientists just couldn't believe how can these people be so healthy? They don't ever suffer from cancer, dental caries, gum disease. Those were unheard of things in traditional societies. And as soon as these, and I'm thinking about the Inuit, for instance, in North America and Alaska and so on, when they started getting exposed to a typical Western diet, the deterioration was, I would almost say, magnificent, how quickly it happened. Within a generation, you know, they developed dental caries, they, you know, gum disease, heart disease and so on, just by changing their diet. So we've got so much examples, so many examples and information around the importance of that.
Well, I know in New Zealand when Western A Price came out here and, you know, traditional Maori were amazing physical specimens, you know, the reports and the images, and they were tall and strong and, you know, really physically capable, mentally really capable. And, you know, when he came out here and he was able to track those who had been exposed to, you know, the Western diet and those that were still eating the traditional diet, and the differences were just exactly like you described.
Yeah. And I think for me, you know, from a medical perspective, it's so sad that the nutritional advice that we've been given, and I mean, I'm sure it's the same in New Zealand, but you can hear it on the television, on the radio, there is all the misinformation that we know is that fats are bad, it's going to give you heart disease, you should eat low fat, and animal protein is bad. It's bad for us and it's bad for the planet. And unfortunately, this misinformation. The more people hear it, the more they believe it, and they apply it, in their own diets. And it is unfortunate because it's really making people sicker and sicker. And, the voices like ours to say it is not the truth, try it for yourself and see the difference. See how you feel and how your body and your mind changes when you actually eat the diet that we as humans have been designed for over millions of years to eat. Because we are not, we haven't evolved to eat a lot of carbohydrates. That's not what humans are today. And that is what we need to understand. It's making the majority of people very sick, and they're suffering because these diseases are chronic, debilitating diseases, which is progressive if you don't change what you eat.
Yeah, and then it's too late, and then you wished you'd done something a lot earlier.
Well, for certain diseases, I agree that, people that's developed dementia already, the disease is too far progressed to turn it around. But we have some other examples which should make people very hopeful. For instance, with type 2 diabetes. And we know that there are many clinicians around the globe that actually look specifically at type 2 diabetic patients, do nutritional intervention, let them start eating nutrient-dense food, cut out the carbohydrates or just cut it back massively, and they very quickly start to decrease their type 2 diabetic medication, and they can even reverse diabetes if people stay with a lifestyle change. And insulin, they can cut back insulin, get them off insulin, get them off the medication. What we need to understand is we shouldn't need to take medication at all. We should be healthy.
Exactly. And that's a very, very hopeful message, I think. I've got another question. Will my menopause belly go away? So with what you're describing, it very well might.
Yes, absolutely. Your menopause belly will go away. You just have to cut back the carbohydrates. Make sure, think about what you eat and what you drink. And I mean, we work with many people and we hear things like, oh, I love my bread, I love my breakfast cereal, I love my oats porridge, specifically being in Scotland, a lot of people like that. I can't do away with, I love my wine or I love my beer. I just can't live without it. It's a decision. It's a personal decision that everybody needs to think, what is the most important thing for you? Do you want to feel healthy? Do you want to look different? Well, you can do something about it if you want to.
It's interesting. I'm getting away from the questions a little bit, and there are a few more there to ask you, but we have a program over here called Matchfit. And so we have Sir Graham Henry and Sir Buck Shelford, who are, our rugby greats and our great rugby coach who sort of led us to World Cup fame. And they run a program where they've got ex-All Blacks who have let themselves go, they're no longer in that peak physical condition, and they put them through a training regime, and we have the sanitarium, Weet-Bix nutritionist sitting there telling everybody to eat Weet-Bix and don't eat too much meat and eat lots of vegetable oils. And they're talking about cholesterol, and the leanest person had the highest cholesterol, which was about 5. And unfortunately, Inga Inga the Winger, who passed away quite young age, just recently. He was part of the program and he had the lowest cholesterol out of the whole group.
So it's tragic, and we see this not just in rugby players, but in other sports people as well. And you often hear about, either a footballer or a rugby player, they in their late 40s, and as you say, they're not actively playing, but they died of a heart attack. And they were trying their best because they were following these recommendations. Oh, I need to cut back on my red meat. I can't eat the fat. And yes, I will start eating the Weet-Bix and whatever, these processed food that's actually, so available for everybody to use. But the very interesting fact is that a lot of these athletes that are supposedly, well, they are very active. I'm talking about marathon athletes as well. As they get older and they get more and more insulin resistant, because for athletes specifically, they've been indoctrinated to tell them you need a carbohydrate boost before you go on the marathon or whatever. You need that energy for your muscles to, the glycogen stores in your muscles, you need that to be able to perform. And there's a lot of evidence now to show that that's not the case. And we know that these athletes actually become insulin resistant, and a lot of them become diabetic when they hit their 40s and 50s, because they suffer from the underlying insulin resistant disease that was never diagnosed. And if they then think, okay, well, we're going to make a super effort to eat healthy according to the guidelines, they actually push themselves over the tip. And just to come back to cholesterol, Sue, cholesterol has been made the scapegoat for heart disease. It is not. And why do I say that? Because cholesterol is a vital and normal substance in our bodies. We need cholesterol. Without cholesterol, we will actually die. It's in every single cell membrane. 2/3 of our brain consists of fat and cholesterol. It's important basic structure for the formation of hormones, for bile acids. So I can go on and on and on. For millions of years, humans have survived and evolved. We've evolved big brains because of the importance of cholesterol. This notion of cholesterol being bad for us came in the 1950s, and it was driven by a guy called Ancel Keys. Now, I must stress that there were no scientific evidence for this, that fat and cholesterol made us sick, but it was a popular belief. Millions of dollars spent in research, which apparently the results showed that it supported the theory. When scientists went back over the last decade and so to reanalyze a lot of those results, we saw that actually the outcome of many of these studies were completely the opposite. We also know that a low cholesterol value is associated with a high all-cause mortality. This has been done in epidemiological studies in thousands of people. So it's the low cholesterol that's the problem, not the high cholesterol. And just to tell the listeners, I mean, my personal total cholesterol is over 7. I've got no problem with that, but I'll tell you, if I do go to my own GP, they would want to put me on statins, which is, I can't see how, something that's naturally made in our livers, cholesterol, cholesterol that's one of the important components in breast milk. Why will our normal physiology make this? And, for mothers to feed their babies with cholesterol in breast milk, how can that be detrimental to our health? This is an answer that nobody can answer. and including your GP will not be able to answer, because there's no truth in that.
And I'm just going to mention, after one of our podcasts that we did some time ago, and we were talking about cholesterol, and I told you mine was 16.9, and you said to me, send me through all your blood test results. And I did that. And you came back very, very happy with everything that you had seen, and all my ratios, and you know, it's very reassuring, because I was happy with it, but it was very reassuring having you say that you were happy with it as well.
Absolutely. And you know, that's one of the things that we do in our metabolic health assessment, is to actually look at these results and do the ratios and so on that support. And we know that there's evidence of what is going to lead to heart disease, for instance, or stroke, and what not. So I remember your results very well, Sue. And yes, they were eye-watering high. I mean, for me especially, I've never seen a high cholesterol value like yours. But when I actually did the calculations, as you say, there's nothing that I could put my finger on to say, Sue, I'm concerned that, you know, you're at risk for whatever. Now, you'll be able to tell the listeners how you feel, you know, what your diet has been through many, many decades, and how you feel and function at your age. And I think the analysis completely supported what you feel today.
Mm. Mm. And I've had a low carbohydrate diet for decades, and I've had a high protein diet, high animal protein diet my whole life.
Yeah.
And one of the stimulus for really taking care of what I ate was exactly what you talked about in the beginning. I had done a research project on hormones and menopause back when I was in my 30s for my university degrees. And I discovered exactly what you described. And I thought, well, okay, I'd seen my mum and my mum-in-law and other people suffering away. And I thought, well, I'm not going to do that. If I don't eat those processed foods, and if I take care of my health, I'll get through it with a breeze. And I've never had a hot flush. I feel fit and well. And yeah, basically don't feel any different than I did before I went through menopause.
All I can say, Sue, is well done. Well done for you for making that decision, because you have taken responsibility and you've ensured that you're a healthy individual, you know, right through your adult life, in spite of your high cholesterol. Now, I just want to mention, if you look, I'm very interested in human evolution. And for at least 3.5 million years, humans, and we were called hominins, you know, during this evolution, have been eating meat. We actually changed from being herbivores, and that was where the chimpanzee and gorilla line that we came from, to being carnivores, a more carnivore diet. Of course, we can eat, well, we can also say we're omnivores, but during that time, we started eating animal fat and protein. And those two components was actually what drove our evolutionary path to develop big brains. You cannot develop this bigger brain on plant material. That's the first thing. The second thing is that our guts changed as well. The fact that we can walk upright is very different from chimps and gorillas. They've got big bellies because they need a big colon to digest all the plant material. They can digest cellulose and things that we as humans have lost that ability. We can't digest all that plant material. In fact, we know that, you know, for instance, the gluten in a lot of the plant material that we eat and in today's products make us sick. It affects our gut, and people would have heard about leaky gut syndrome and so on, and it can be very debilitating. So we need to eat the kind of food that for which we were designed. That's basically it. So what makes us healthy is how our bodies work.
All right, I'll get back to a couple more questions. So we've got a little bit away from menopause, but I think it's a really fascinating, important conversation to have. So I've got a comment here. My GP has informed me in writing she will not be recommending any more insulin testing. So that's a little bit sad.
Oh, it's really disappointing. But the GPs are also not informed. You know, we were in medical school taught the traditional view that everybody holds today. There's unfortunately a lot of influence of the pharmaceutical industry in the teaching and the curriculum of medical schools, and they want to retain the traditional view because it's in their interest. You know, food, drink, and pharmaceutical industry are all benefiting financially from these chronic diseases. It's a different topic, but it's a very sad topic. What I would suggest to your listener is that if it's important for them to do insulin testing, it is available privately if they're prepared to pay for it. But there are other measurements that they can also look at. So it's not the only measurement. For instance, in my own metabolic health assessment program, I don't even ask people to submit their insulin result because it's so difficult for many people to get, but there are other ways to do the assessment.
Well, I know this lady very well because her GP told her to go and find a nutritionist. So she came and found me.
Lucky her.
And she's really pleased. I'm sure she won't mind me sharing this. She's currently 77, incredibly fit and strong. And when I first met her, she was on blood pressure medication, had very, very high blood pressure. She was eating the healthy diet. She had the whole family on the healthy diet, and she had kidney problems for many, many years, and she was due to have kidney surgery and have a kidney removed. And we got her off her blood pressure medication. We have got her kidney function back to really, really good function. And she just feels amazing, and she lifts weights in her gym, and she rides her mountain bike, and it's an amazing success story of someone who's really put in the work and the effort to get there. So,
well, all I can say is congratulations to both of you, and I think that should be a good example to the listeners of what can be achieved. And don't think when I'm past 60 or 70, it's too late to make a change now. It's not. And this is a prime example how even little changes anytime will add to make you more and more healthy. But well done.
Yeah, fabulous. I'll just have a quick look through some more questions. So there are a couple of questions about one about painful sex during menopause and vaginal dryness. So I don't know if you've got anything there to comment on, or is there any way that people can be helped with that?
Yeah,
without giving medical advice.
Yeah, no, not specifically, Sue. I think that people should speak to their gynaes or their GPs about that. I've got nothing else specifically to advise on that other than what I've already said. Right. So for any symptoms, really, I would go back to what we've discussed so far. If that doesn't help, by all means, go back to your gynae, go back to your GP, and there may be something that they can help you with.
I've got 2 more questions here. So one is, am I too young, 42, to be going through menopause?
No, not really. It's not a specific age that, menopause should start. I think 42 is not too early. We see that often. It's usually just after 40, and it can be soon after 40. Some people say typically it's 45 to 55. So there is a variation. And some people will be a bit earlier and some people will be a bit later. So I would not be concerned about that.
Okay. What about osteoporosis? Any comments about that?
Yes, I think we need to be aware of that. There's a lot of women suffering from that. Once again, I always refer people back to what they eat. And one of the things that we've been told over the years is to eat low-fat products. And I think that's one of the problems we have, because if you eat low-fat products, we need fat, full fat products, to be able to absorb the fat-soluble vitamins A, D, E, and K. And vitamin D, for instance, is very important for us to help with the absorption of calcium and magnesium. And we need that to keep our bones and our skeleton strong. So if you once again, if you don't get the correct nutrients and micronutrients, you may have problems with your bone density. So I would advise people to go back on full fat products. They may have to even take supplements for vitamin D, and even magnesium is very important. So those are the things that I think they should concentrate on.
And I'd just like to add something there about the supplements, because I think sometimes, that there's we have some great supplements now, like liver and organ supplements. So, if you don't want to eat liver, which is a great way to get a lot of those nutrients and get that nice vitamin D, vitamin A balance as well, that's so important. You can do organ meat supplements, or even bee pollen, if you can tolerate bee pollen, can be probably quite a useful supplement, more closely related to our food than the synthetic supplements that sometimes we get. Yeah. Anyway, that was just a thought. And then there's a question here about herbs. What are the best herbs to use? And I know there are a lot of herbs out there that are used to help with menopause symptoms. The clients that I see that use them seem to have varied success, and maybe short-term success. They feel better for a bit, and then it all goes away.
Yeah, I think the same would go for herbs. We love herbs. We love cooking with herbs and so on, and that's absolutely great. But I think for menopausal symptoms, once again, Sue, and I don't want to sound like a broken record, make sure that you get the correct macronutrients and the correct macronutrient composition into your diet. And yes, by all means, use the herbs, but the herbs is not going to override the condition of insulin resistance. If that's the underlying condition, you can eat mega quantities of herbs. It's not going to get rid of your underlying metabolic condition. So eat the herbs, but focus on your metabolism.
Well, it's been an amazing hour again. I love listening to you. I could listen to you for hours, and you've got such a wealth of information. Before I pushed record, we had started talking. We got talking about your food, because Izzy is always posting these delicious looking meals that you two eat. And so you started talking about how you start your day. So maybe we could end tonight's session on how you start your day and how you eat and what do you choose for food. And I'll just give another little plug for your recipe books as well, which I'm always sharing and telling people if they want good, quick, simple, delicious tasting meals, it's a great place to find them.
Thanks for that, Sue. Yeah, typically we eat one meal a day. It's usually around lunchtime. And it's very interesting if you start eating the correct food that suits your body, that we don't need to eat a lot of food. And it's a natural process. I never thought when I was still on a high carb diet that I would ever say something like this, but it works. I start my day typically with a bullet coffee. I know it's not everybody's taste, but I love that. And how do I make that? I use some butter, say a teaspoon or two or three teaspoonfuls of butter and 2 teaspoonfuls of coconut oil. And I froth that up with the coffee. And I'm really a dairy fan, so I add a little bit of milk and I add a little bit of cinnamon on top. There goes your herbs and spices. And to me, it's just the most a lovely, energizing drink. A lot of good fats for me, because fat burning is what we need to aim for. So I get all of that. And it keeps me satiated. It gives me energy, because we didn't get to that, but I still believe if you can run on ketones, it's so much better than running on glucose.
Yeah. And we ran out of time for that, but we have got 2 previous podcasts that we can refer people back to as well. And who knows, we might get together and do another one at some stage. It's always so great to talk to you. Yeah. So you're doing 1 meal a day. Are you having a snack or anything in the afternoon, or just?
Yes, do have a snack sometimes, late afternoon, early evening. So it could be, once again, maybe some cheese, maybe if there's a little bit of leftover sometimes. I also, as I say, I'm a dairy fan, so I will even drink a little bit of milk. And mixed with cream. I know not everybody, there are people that's lactose intolerant, but for people that can do that, it's a very lovely, healthy drink to have.
And you look like glowing good health too. So I think the results speak for themselves. Thank you so much for coming along this evening.
It's always lovely to speak to you. Thank you very much for the invitation.